to high school here and then attended college at Yale, where she majored in French literature. And she then came to the University of Michigan Medical School, where she did her medical school training, her cardiology training, her fellowship in invasive cardiology, and joined the faculty. And Claire, from the very beginning, has been very, very interested in women's issues. She's been a supporter of our women's health program from the early days when she was a fellow and when we got involved. And when a former women's health heart program was started here in 2003, she became the obvious director of that, and she has led the women's heart activities at the University of Michigan since that time. She's a great collaborator for the women's health program. She's a terrific colleague for those of us in this department, and she's here this morning to provide an update appropriate enough on heart disease in women. Thank you very much for coming, Claire.
Thanks, Tim. Let's see. Good morning, everybody. Thanks for inviting me back. I think I gave grand rounds here several years ago, maybe, yeah, like 10 years ago. So I think it's time for an update. And a lot of new things have happened. A lot of new information on heart disease in women. I thought it would be interesting to start with a few cases that kind of illustrate the complexity and the breadth of heart disease in women. Cases are always interesting to go through. So I have really a span of different types of heart disease in women to tell you about here through these cases. So this first patient is a long-standing patient of mine. She's a 67-year-old retired professor of nursing and came to me probably 3-4 years ago now, complaining of increasing chest pain with minimal exertion. Really very classic anginal symptoms. One flight of stairs would cause heaviness and pressure in her chest, carrying heavy objects. She had multiple cardiac risk factors: hypertension, hyperlipidemia. She was overweight and glucose intolerant. She had reflux as well. And she'd previously been given a diagnosis of microvascular angina. She had a fairly normal physical exam. Her blood pressure was a little bit borderline. Cardiac exam was really unremarkable. And her EKG, it doesn't project that well, but it's really fairly unremarkable. It's a normal sinus rhythm. She's got some flattening of her ST and T waves, but nothing else really jumps out at you. She was on a good set of meds. She was on an aspirin a day, a beta blocker, glucosamine for her joints, a little bit of a diuretic, some long-acting nitrate, and cholesterol medicine, and an ACE inhibitor. So we thought that she had progression of her symptoms in spite of being on a fairly good medical regimen, and we thought that we probably should go ahead and do a cardiac catheterization. So she went to the cath lab. She had normal left ventricular filling pressures and normal left ventricular function. Had really only minor coronary artery lesions. A 20% blockage was her greatest percent narrowing. And I asked my colleague, because I didn't do the case, to do a coronary flow reserve assessment in one of her epicardial coronary arteries, which is to give intracoronary adenosine and see how much the flow augments over baseline. So she had a coronary flow reserve of 1.6. So with peak adenosine infusion, her flow was 1.6 times greater than at baseline. And normal coronary flow reserve is considered to be at least 2.5 times the resting flow. So she had abnormal coronary flow reserve, which is really pathognomonic of microvascular angina. And this is not a test that we routinely do, so a lot of times people ask me, well, how do you know that this person has microvascular angina? Most of the time, it's a diagnosis of exclusion. If they have classic symptoms, an abnormal stress test, no or minimal coronary disease, usually we say, and they're responsive to anti-anginal medications, usually we say, well, they probably have microvascular disease. So for this lady, we really tried to ramp up her medical therapy. We asked her to consider L-arginine, which is a nitric oxide donor, which has been shown to be helpful in some studies. And we really also emphasized exercise as one of the mainstays of therapy, because exercise actually helps to liberate nitric oxide in the vasculature and correct the microvascular abnormalities and endothelial abnormalities that you see in this disease process. So that's case number one. Case number two, I actually saw this weekend when I was on call, and I thought fit nicely into this presentation. This was an 80-year-old woman that we were asked to take emergently to the cath lab from the emergency room. It was Sunday afternoon after she had presented with a 2-day history of malaise, nausea, fatigue. Pressure in her chest was part of it, but it wasn't the main thing. She had EKG changes, though, which were quite concerning, and a positive troponin. And this lady had previous vascular disease. She had had a AAA repair the year before. She was known to have moderate aortic stenosis. She had had a carotid endarterectomy. She was a smoker and was hypertensive. Also of some interest, you'll see later, she had been taking venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, at a fairly high dose, but had stopped taking that a week ago without tapering it. And so her EKG at baseline, again, was pretty unremarkable. But on presentation, I hope this projects, she's got ST elevation in her anterolateral leads, really all the way from V2 out through V6 and 1 in ABL with T-wave inversion, sort of terminal T-wave inversions in those leads. Pretty concerning, especially when my fellow put an echo probe on her chest and found that her entire anterolateral wall wasn't moving. So at that point we were very concerned. I'll just show you the follow-up EKG because she really has evolutionary ST and T-wave changes which make you think this woman has had an anterolateral MI, because that's what those changes look like. So we did a catheterization, and to really our big surprise, we don't see any coronary artery lesions here. She's got tortuous coronaries, which goes along with her history of hypertension. But no blockage. You would expect to see a cutoff in these arteries to go along with that presentation, that EKG, and that echo. So I'll just let this run through for a second. Nothing in the right coronary either. Tortuous, but normal. And then really the clincher for the diagnosis is the ventriculogram. And what you see here is a classic Takotsubo cardiomyopathy. So what this is her entire anterolateral wall, apex, and inferior wall is not moving. Stop it there. And just the base of the heart is moving. And this is a disease that's also known as broken heart syndrome. I don't know if any of you have heard of that. Which much more commonly presents in postmenopausal women than any other segment of the population. And I'll tell you a little bit more about that later. Patients can be quite sick, look like really be in cardiogenic shock, but tend to resolve and completely normalize their left ventricular function if you can support them through the acute event. And I'll tell you about the etiology and all of that. This case just happened on Tuesday when I was in the cath lab. And is sort of another example of the breadth and complexity of heart disease in women. A 56-year-old woman that I got a call from one of my colleagues in Brighton Clinic about, he said, well, this lady was seeing one of the internists out there. She has kind of a 2 or 3 month history of chest pain. We did a dobutamine stress echo on her, and it was really kind of subtly positive, and she had maybe some EKG changes. I'm not sure there's anything there, but the internist was concerned, and if you're not busy in the cath lab, I said, it's a slow day today, we'd be happy to take her, no problem. So she did have risk factors. She was a smoker, she had a family history, she had high cholesterol. She also was being treated for depression and anxiety, had a lot of kind of somatic complaints. And also was being treated for a GI condition, lymphocytic esophagitis. And so really they'd been focusing her chest pain on her esophagus and esophageal symptoms. She also had had a negative stress echo a month earlier at St. Joe's, but had been exercising and really wasn't able to exercise very much. And they made note that it was probably non-diagnostic because of the low cardiovascular workload. Her EKG, also essentially unremarkable, but her cardiac catheterization shows 3 vessel coronary artery disease. So she has a long, tight lesion in her LAD, a long lesion in her circumflex, and you can see the right coronary coming in because it's totally occluded and filling by collaterals. So we were thinking that this lady was going to have esophageal chest pain. Weren't really sure she was going to have anything. We were really quite surprised to find severe 3-vessel coronary artery disease, and we referred her to surgery. So you can see her right coronary artery cuts off in the mid-segment. And then the last case is a 31-year-old woman. She was seen in the springtime here in transfer from another institution, who developed crushing substernal chest pain and anterior ST elevations 3 weeks after delivering her 3rd child. She had no significant past medical history. She was found to have an elevated cholesterol when she presented. And I just have an image to show you, and maybe you can see those arrows are pointing to kind of a shadow double line there in her left anterior descending coronary artery, and she had a dissection going all the way down her coronary artery. And she was very, very sick. She came in cardiogenic shock, had a balloon pump placed, was in the ICU for days, eventually recovered, but it now is left with a cardiomyopathy, EF about 40%, and has small children at home to raise. So I think these cases are a nice illustration of how complicated heart disease in women is and how varied it is. I want to talk about, hopefully, several of the issues that we touched upon in these cases. So I'm going to go through the pathophysiology and the prognosis of coronary heart disease in women and the relationship to gender. What is different about risk factors for heart disease in women? What is optimal treatment that is gender specific? And what are non-coronary heart disease causes for acute coronary syndromes? And then also microvascular disease. What is it? Does it need different treatment strategies? How should we manage it? So probably several of you have seen these curves before. This is heart disease incidence, mortality incidence in the United States. When you're starting with the 80s and going right up to 2004. There's a nice downward trend in both the curves for men and for women, but the interesting thing is that the curves actually crossed in 1984 when more women than men died of heart disease for the first time, and that has continued. So the deaths for men are declining, as are the deaths for women, but women are dying in greater numbers of heart disease. And these downward trends that we see at the end of these curves unfortunately threaten to be reversed because of the obesity epidemic and consequent type 2 diabetes epidemic that we have in our society. So just some facts about coronary heart disease. Women present differently and in general have a more complex presentation. They more commonly have a silent myocardial infarction than men. Even after taking a careful history, 50% of women are considered to be asymptomatic. Young women who have a heart attack are at higher risk for death than age-matched men. Acute coronary syndromes are more common in women, even though occlusive coronary artery disease is less commonly found. Women will often have an MI without ST segment changes, and women are older when they have their first MI than men are. Gender differences in stroke. Stroke, again, is more common in women than it is in men, and women experience the majority of stroke deaths. Older women are at higher risk, and also hemorrhagic stroke is more common in women. So talking about prognosis after an acute MI by age, if you look at the early age groups, you can see that in their 50s, women who have an MI are almost twice as likely to die as men in their 50s. This has to do with several factors. Young women tend to be recognized late when they come in with an MI because you don't think about that woman coming in with an MI. You just don't key into that presentation. Women have a less typical presentation. They don't tend to have the Hollywood heart attack that people talk about, where the guy clutching his chest with the sweat pouring down and it radiates down his arm. Women tend to more commonly complain of just sort of malaise, not feeling good, something's wrong, I'm kind of sick to my stomach. Very similar to the elderly woman who turned out to have Takotsubo that we saw on the weekend. And you see these same mortality differences after bypass surgery, especially for younger women, where they are more at risk of death, especially when they're young. This also has to do with the fact that by the time they get to bypass, for men, it's more commonly going to be an elective procedure, and for women, it's more commonly going to be an urgent or emergent procedure. And we know that you don't do as well when you have an operation done urgently or emergently. Also, women have smaller vessels. They're harder to graft, and women have more bleeding complications. Now, Viola Vaccarino, who wrote the paper about sex differences in myocardial infarction, reanalyzed her data 10 years later and found that the unadjusted mortality rates had gone down, and the mortality trends she thought were mostly accounted for by comorbidities and by clinical severity at presentation, but she also thought that there was, in the intervening 10 years, a better recognition of risk factors and of coronary heart disease in women versus the earlier studies. So that is gratifying. Unfortunately, we still see delays among women themselves in coming to treatment, in recognizing that they may be having a cardiovascular event. So there's an increased time to diagnosis. And for physicians taking care of women, there's an increased diagnostic uncertainty because of the decreased prevalence of obstructive coronary heart disease. So we cardiologists are not good at knowing what to do if we don't see a nice fat blockage that we can fix with a balloon or a stent. We're really good at that. Interventional cardiologists are great at doing that. But if you have a woman with an acute coronary syndrome who doesn't have that, who has microvascular disease or diffuse coronary artery disease, we're sort of in a quandary. And the old way of dealing with that was to say, well, you don't have heart disease, your chest pain must be non-cardiac, I don't need to see you anymore. And that may be the case for some women presenting with chest pain, but for many of the women, I believe that what they really have is microvascular disease, which also needs aggressive treatment. It just doesn't need interventional treatment. The fact is that the typical female presentation of coronary heart disease is more complex and more multifactorial, and that vascular dysfunction-related signs and symptoms of coronary heart disease that go along with non-obstructive coronary artery lesions do pose a significant problem for women. They consume millions of healthcare dollars, and they result in a decreased event-free survival, and I'll show you a little bit of data about that. So in spite of having an increased prevalence of angina, women have a lower prevalence of obstructive coronary heart disease, and symptomatic women undergoing angiography have a decreased extent and severity of coronary artery disease in spite of being older and having more risk factors. There is something different about the way atherosclerosis presents and affects the arteries in women. I'm not saying they can't have obstructive coronary disease. We saw that case that I had the day before yesterday, very severe obstructive coronary heart disease. But that woman might also have presented with relatively clean coronaries and microvascular disease. And women, in spite of having relatively less obstructive lesions, end up having a worse prognosis than men. So there's all sorts of conundrums and complicating factors here. So just to reiterate, the women have less angiographic coronary artery disease. They tend to have lesions located more osteally, at the beginnings of coronary arteries, which are harder to detect and harder to treat. They have a lower prevalence of heart attacks, but more severe congestive heart failure symptoms, higher Canadian Cardiovascular Society class of angina, more microvascular dysfunction, more abnormal vasomotor tone, more endothelial dysfunction, all these entities that we have a hard time figuring out how to treat optimally. There's also this thing called plaque erosion versus plaque rupture. We classically think of an acute MI as presenting with plaque rupture. You have a plaque that may not be all that severe, but the surface sort of breaks off, and then all that cheesy cholesterol stuff oozes out of it, and then that causes platelets to glom onto there, and that causes thrombus formation that then becomes obstructive, and you have an MI. So an erosion is where you don't necessarily have a rupture of the plaque. You have a plaque that's there. There is some healing thrombus associated with it. It has less of a prodrome, and it tends to carry a worse prognosis. And pathology studies on autopsy of women and men, women more commonly presented with these plaque erosions, which carried a worse prognosis. This is sort of another way of thinking about differences in pathophysiology. Classically, you think of a male presentation as being a discrete blockage, again, that you can see on an angiogram, that you can fix with a balloon and a stent. The lower panel shows what might be a schematic of coronary heart disease presentation in a woman, where you end up with the same decrement and flow by the end, if you look at a pressure tracing, but there's no one spot where you could stick a stent in because the whole vessel is abnormal. And again, so this won't successfully be treated with balloons and stents. It has to be treated with medication, with lifestyle changes. This was a schematic actually that the New York Times carried a few years ago, and they talked about the typical obstructive coronary heart disease pattern where you can see a blockage, in this case in that right coronary artery, right at the ostium, and that tends to present more commonly in men. It also can be seen in older women more commonly. I always think about the age ranges of coronary heart disease presentations in women, sort of the perimenopausal presentation. I more commonly will see microvascular disease. By the time women get to their 70s and 80s, their disease is more like a male pattern of disease. And I tend to think of that as because their estrogen has been gone for 20, 30 years at that point. And so that the estrogen effect, which is what I believe makes the vascular disease different in women, has by that time gone away, and their disease has become more like the typical obstructive male pattern. So many of you probably have heard of the WISE study. This was an NHLBI-sponsored trial, which is still generating lots of data, the Women's Ischemic Syndrome Evaluation. It was a 4-center study where almost 1,000 women who presented with suspected acute coronary syndromes underwent cardiac catheterization, and then multiple other types of tests like the adenosine coronary flow reserve assessment, nuclear magnetic resonance imaging, lots of things that you wouldn't normally do. They had sort of extra testing to try and figure out what was going on. And in this study, 2/3 of the women who came in presenting like an acute coronary syndrome ended up having no or minimal coronary heart disease. This would certainly not be the presentation had you examined a male group of patients. The fact was, though, that even though 2/3 of the women had no or minimal blockages, they still had a significant event rate, 9.4, almost 10% death or MI rate after 4 years, even if they had no or minimal disease. So if they had significant disease, they did worse. They had almost a 14% event rate, but it wasn't benign. The point of the study was that it wasn't benign to have minimal disease for these women. They also analyzed coronary flow reserve and found that having an abnormal coronary flow reserve does predict a decreased event-free survival. So not necessarily death, but coming into the hospital with acute coronary syndromes again and again, having an MI, and consuming healthcare dollars. When you look at multiple large trials which have analyzed different medical therapies, different interventional therapies for acute coronary syndromes, the women have consistently been twice as likely to have normal or non-obstructive coronary arteries as the men. So for example, in the first trial, Gusto, women had an almost 20% incidence of normal coronaries, the men a 9% incidence, and so on. It goes right down the line. So I showed you an example of Takotsubo cardiomyopathy. I just want to come back to that for a second. This syndrome is also known as the broken heart syndrome, and some of you may have heard of it in that way. The name Takotsubo actually is from a Japanese, it apparently is an octopus trap, and it's called that because the octopus trap is shaped that way. It has a very narrow neck and a bulbous end so that the octopus can find its way in but can't get out. And it's called that because that's the way the ventricle looks classically in this presentation. And what you see is acute, profound left ventricular dysfunction presenting as an acute coronary syndrome in the absence of any significant coronary artery disease, usually triggered by profound emotional or physical stress. As I said, it has this LV contraction pattern, which is typical. It's called apical ballooning. And in studies that have looked at the mechanisms, it seems to be related to enhanced sympathetic activity. The incidence, it's about 2% of all acute coronary syndromes, but 80% or more of the people that present with this are postmenopausal women. So interestingly, with the lady that we saw who had been on a SNRI and recently stopped it, there was a case presented a year ago at one of our ACC meetings where someone had been placed on Cymbalta, also an SNRI, and the mechanism of her Takotsubo presentation was postulated to be the norepinephrine excess that resulted from taking this drug. I don't know whether this lady, who didn't have any one emotional trigger for her presentation, I talked to her and her son pretty extensively afterwards trying to pinpoint something, and all he could tell me was she was on this drug and she just stopped it. And so I don't know whether the shifts in circulating norepinephrine could have played some role. It's just speculation on my part. Turning to the young woman, the case, I'm sure all of you have heard of spontaneous coronary artery dissection. It's an extremely rare event, and I unfortunately don't really have any numbers for you. The pathophysiology is unclear, but is thought to be contributed to by hormonal changes, especially after pregnancy, potentially the hemodynamic stress of pregnancy, labor, and delivery, which causes shear stress in the coronary artery, and essentially causes that coronary artery, most often the left anterior descending, to just rip right down. Some risk factors or some observations that people have made is that advanced maternal age, I hesitate to call 31 an advanced maternal age. I had my first child at age 35. I guess that's considered to be advanced maternal age. Multiparity is also considered to be a risk, and this is a very high death rate, at least 30%. So all kinds of strategies are used to deal with this. I've had patients go emergently to bypass surgery. I've had patients get stented, and I've had patients just get observed and supported. I don't think there is a right answer. You have to individualize. What I have seen happen is when you try to intervene, you put a stent in and the artery just keeps ripping right down it. So you end up stenting all along, and it's a nightmare. It literally is a nightmare in the cath lab. And then if they survive, they recover, and they usually end up doing pretty well, although it depends on the extent of their residual left ventricular dysfunction. So turning towards risk factors, modifiable cardiac risk factors in women are very, very common. More than half of our society is overweight or obese. Almost a third engages in no leisure time physical activity, and at least 20% are smokers. And one thing I'll say is that when I see younger women who actually have severe coronary artery lesions and obstructive coronary artery disease, they are almost always smokers. So smoking, and then I would say type 1 diabetes is the other thing that really changes the presentation from the less obstructive coronary artery disease to the really bad obstructive lesions. So those two risk factors, either they're long-time type 1 diabetics or they're smokers. And I have one statistic that over half of the middle-aged 40 and 50-year-old women that present with heart attacks are going to be smokers, over half. There's a clear association between increasing body weight and coronary heart disease mortality among women. This is from the Nurses' Health Study. So over 100,000 women that were initially free of heart disease and then were followed for 20 years. And we did some studies looking at flow reserve and found that there were clear associations between body mass index, so increasing body mass index was associated with decreased myocardial flow reserve. And interestingly, that correlation seemed to be associated with C-reactive protein. So obesity itself is considered a pro-inflammatory state, and that increased CRP associates to decreased flow reserve. You all are the ones who can work with women because you are the ones who see them at earlier stages in life, presumably before they're going to have coronary heart disease. And so counseling about weight gain during pregnancy, which is the time that many women gain weight and then don't lose it again, is a really golden opportunity for obstetrician gynecologists. So some suggested weight gain, whether you're underweight, normal weight, overweight, or obese, are given here. And then women commonly gain weight during menopause. Most often that's related to changes in lifestyle, to reduced exercise. Women do tend to experience a shift in weight distribution after menopause as well, with more central weight gain occurring, probably due to the loss of estrogen. But weight management is not, there's nothing magic about it. It's the same for women as well as men. You balance your calorie intake and expenditure. There are some unique weight issues for women in terms of medications associated with weight gain, some hormones, corticosteroids, diabetic medications, antidepressants, bipolar agents, and some atypical antipsychotics. And this is a huge concern for women. I'm sure you've had people ask you, well, is this going to cause me to get fat? I don't want to take it in that case. And it's something to be cognizant of. We also know that exercising is associated with a clear-cut risk reduction in heart disease risk for women. And it can be walking, it can be aerobic exercise, any physical exercise where you get a certain number of METs in per week. And the highest MET level here is associated with basically 5 days a week, 30 to 45 minutes of exercise consistently per week. And there is a clear-cut reduction in risk. We also found, looking at flow reserve again, that when we asked women whether or not they engaged in moderate physical activity regularly, those women who said yes, at least twice a week, I exercise for 30 to 45 minutes, they had a higher myocardial flow reserve than those women who said, no, I don't, I'm sedentary. And one easy risk predictor that really anyone can do in their office is just to ask women what they typically do and what is their highest level of exertion in a typical week. And there are tables that give you the MET levels for different household activities, for walking, for running, bicycling, etc. We know that women who have a max MET level of less than 5 have a higher mortality, completely independent of whatever else they have in terms of disease. And if you have a MET level that's greater than 10 METs on a regular basis, even if you have diagnosed coronary artery disease, you're going to do much better. Cigarette smoking, I told you already, is a huge risk factor for women. Unfortunately, smoking cessation is slower among women than it is among men. And the risk of MI seems to be higher for current female smokers than male smokers. So there's something about the nicotine that affects female coronary arteries more adversely. My colleague Lisa Jackson just published an article on this in the American Journal of Cardiology. It got a lot of press in the cardiology news, cardiology world, where she analyzed data from the Blue Cross Blue Shield consortium, so all Michigan data, and found that female smokers had a greatly elevated risk, even in comparison with male smokers, for coronary heart disease events. Hypertension is associated with elevated risk, and hypertension usually occurs in concert with other risk factors. And unfortunately, hypertension is essentially ubiquitous in American society. So among older women, the prevalence is something like 80%. So it's almost guaranteed that the elderly women you see in your practice are going to be hypertensive. It's also a fact that we don't do a great job at managing hypertension. Oftentimes patients are put on a dose of diuretic and it's kind of a, there, I'm done, your hypertension is treated. And the fact is that that's not usually the case. Most patients need a combination of drugs, they need continued follow-up, they need to be measuring their blood pressures at home, and it needs to be an ongoing management issue. And even high normal levels confer an increased risk. So in this diagram, over a 14-year period, there was at least a quadrupled incidence of events, even among the people who had high normal levels. That's less than 140, but over 130 for systolic, versus those individuals who had normal or optimal blood pressures. Couple of other issues related to high blood pressure in women. Oral contraceptives do raise blood pressure by a couple of points. It's usually not a problem in young women who have low blood pressures, but it's something to be cognizant of. And we know that pregnancy-induced hypertension is associated with long-term increase in cardiovascular risk, and also polycystic ovarian syndrome, which I'm sure you see a lot of in your practices. Preeclampsia is something, this is in the newest set of the guidelines. Preeclampsia, gestational diabetes, pregnancy-induced hypertension, all three of those things should be asked about in the women that you see in your practice, because those things confer an increased heart disease risk down the line. Preeclampsia, at least a 3.5-fold increased risk of hypertension when you follow these women. Also an increased risk of ischemic heart disease long-term, increased risk of stroke, and DVT down the line. And people postulate that preeclampsia represents an unmasking of endothelial dysfunction and other vascular disease in these patients. And really what it means is that we need to try harder on prevention in the women we see that have had this type of issue during pregnancy. Similarly, for gestational diabetes, it's associated with a documented impairment in endothelial function and changes in the placental vessels, including decreased nitric oxide synthesis, reduced blood flow in the placenta, and increased placental vascular resistance. And type 2 diabetes will occur very commonly within 5 years in these women who've had gestational diabetes. It is also associated with other cardiac risk factors. We know also that mothers with small for gestational age infants show endothelial dysfunction in their vasculature. They have impaired insulin sensitivity and markers of subclinical inflammation. Again, all of these things being risk factors for future development of heart disease. There are other associations with small for gestational age babies, including smoking and chronic hypertension as well. And then when you look at pregnancy-associated hypertension. This study looked at the risk of someone who had pregnancy-induced hypertension, preeclampsia, versus a normotensive mother, further on down the line, developing high blood pressure or developing renal dysfunction in the form of microalbuminuria. You can see that more than a third of the women who had pregnancy-induced hypertension later went on to develop high blood pressure, and 14% developed microalbuminuria. So pretty high percentages for preeclampsia. 20% developed high blood pressure and developed microalbuminuria. I talked about blood pressure elevations with oral contraceptives. So this is for combined estrogen-progestin oral contraceptives. There was a small but measurable increase in systolic and diastolic blood pressure. Again, something to be aware of. And then polycystic ovarian syndrome. These women more commonly have other risk factors. They are more commonly obese. They more commonly have elevations in cholesterol and elevations in blood pressure when you compare them with normal women. Again, incidence of hypertension higher in polycystic ovarian syndrome women, 23% versus 6.9% in controls. And their BMIs are going to be higher. And as well, their LDL and total cholesterols are higher than women who do not have PCOS. So again, an opportunity in the women who present with polycystic ovarian syndrome to talk about long-term risk factor reduction. You all know that diabetes confers a huge coronary heart disease mortality increase, and diabetes seems to be, again, a worse risk factor for women than it is for men, because it seems to affect the vasculature even more adversely for women than it does for men. And unfortunately, the prevalence of diabetes is increasing markedly in our country. The prevalence is higher among ethnic minorities, including African Americans, Hispanics, American Indians, and Asian Pacific Islanders. And we have an increasing minority population in the United States, which means that the prevalence of type 2 diabetes is increasing at a rapid rate. I want to spend a little bit of time talking about treatment differences. I think I went over all of this, and I'm going to skip it in the interest of time. This was an analysis of the Blue Cross Blue Shield database that we did a year ago, and found that women have an unadjusted higher death rate and higher complication rate after undergoing percutaneous coronary intervention. They have a much higher risk of vascular complications, of contrast-induced nephropathy, and of bleeding risk, need for post-procedure transfusions and GI bleeding. When you correct for their body surface area and for their creatinine clearance, you no longer see the increased death rate, but you still have more vascular complications, higher risk of nephropathy, and higher risk of bleeding, even after correcting for body surface area and for baseline kidney function. But the interesting thing is that body surface area seems to be playing a major role in the increased death rate. So in this schematic, you can see that the lowest body surface area categories, men and women did much worse than if they were larger. The men actually did even worse than the small women. But the striking thing is that there's not very many small men. There's 132 in this study, whereas 1,171 women. So if you don't adjust for body surface area, the larger number of small women is what's going to skew the results towards women doing worse. And we see the exact same thing when we look at the kidney function. The kidney function, so women who have, or patients who have creatinine clearance less than 30 are going to do much worse. We know that. But half as many men had that low creatinine clearance versus women in this last set of bars. Another meta-analysis that looked at the treatment of acute coronary syndromes found differences in how aggressive we should be in managing men versus managing women. So if men and women come in and have high risk markers, that would be positive troponin, clear-cut EKG changes, going to the cath lab early, i.e. an early invasive strategy, is associated with improved survival. But in low-risk patients, those who do not have positive troponin, those whose EKG changes are sort of iffy, women were more benefited by being conservative, by waiting and not going to the cath lab, whereas men still did the same or better if you took them to the cath lab early. So because women have a lower prevalence of obstructive disease, they're more likely to be harmed by an invasive strategy than men. Just ending up with pharmacologic therapy, we know that there is proven benefit for aspirin, for statins, beta blockers, ACE inhibitors, for endothelial dysfunction and microvascular or non-obstructive coronary artery disease. One of the best things seems to be exercise, again, because exercise serves to normalize the vascular endothelium and releases nitric oxide into the vascular endothelium. Nitrates can be very effective for symptomatic relief. Tricyclic antidepressants in one small study have been shown to be beneficial. L-arginine, which is a supplement that you can buy in the drugstore, has actually been shown to be helpful in a couple of small trials because it acts as a nitric oxide donor and counteracts endothelial dysfunction. The problem is you have to take a lot of it, 3 grams 3 times a day, which is hard to swallow. They're apparently huge pills. And so we've had women in our practice that have done very well, but they have a hard time taking all those pills. And then ranolazine, which is a newer anti-anginal agent, can be very helpful. There have been several studies that have shown that to be helpful in women with microvascular angina. I don't have time today to talk about hormone replacement therapy. It's a topic that we thought was black and white back in the 60s. Then we switched completely and thought it was black and white as a no in the 90s. And now I think we're back to not really being sure whether it's good or it's bad in terms of cardiovascular risk. Maybe good for some people, maybe not so good for others. It's an interesting topic, and I think we're going to learn more with more trials in the next 5 years or so. I'm going to skip over this. The Women's Health Study was a study of aspirin, which did not show benefit for coronary heart disease risk reduction for women who did not previously have heart disease until they reached age 65. And the interesting thing was the study was associated with a reduction in stroke risk. So it's complicated. We typically do not recommend aspirin for primary prevention for women under age 65 unless they're felt to be at high risk, they have multiple risk factors, they are diabetic, or if we think that their stroke risk is higher, because aspirin is helpful in preventing stroke. Over age 65, the benefit-risk ratio shifts, and we think it is helpful for primary prevention. But there is less evidence for primary prevention in women under age 65. Very briefly, cholesterol, LDL cholesterol is important in women, but you also should pay attention to low HDL levels and to higher triglyceride levels. And I have seen women in my practice who really had no risk factors. Their LDL level was essentially normal, really in the 130s, not bad at all. But they had low HDLs, and they were coming in with coronary heart disease. So I pay a lot of attention to a low HDL level in a female patient, especially if she also has a family history of heart disease. We don't, in the Framingham risk score, family history is not considered as a risk factor, and I believe that family history should be considered especially as an important risk factor for women. So I always ask whether they had first-degree relatives under age 55 or 60 who had heart disease. Insulin resistance and metabolic syndrome should not be ignored in women. It's also an important risk factor. I'm going to skip over some of these things just in the interest of time. We have good evidence now that statins will reduce risk for primary as well as secondary prevention. And so I tend to be fairly aggressive in putting patients on statins. It's very difficult, especially in Ann Arbor. Sometimes patients say, oh, those statins, they're terrible drugs. I had a friend and her muscles ached so bad after, I've never taken that. And so you have to do some PR and really ask people to recognize that the vast majority of patients who take statins do very, very well with them. And we probably have more evidence for risk reduction with statins than we do any other drug classification. I talked about some benefit for Renolzine. I'm going to skip over the HRT data just in the interest of time. And end with some gender-specific guidelines. If you have a woman in your practice that has obstructive coronary heart disease, she needs aggressive, evidence-based, really gender-neutral treatments. She needs aspirin, beta blockers, ACE inhibitors, statins. These things are not specific to women versus men. You should consider gender-related non-CHD causes for acute coronary syndromes in selected patients, like could this patient be having Takotsubo? Could this patient be having a spontaneous dissection if it's the right demographic? If it's a young woman after pregnancy, that would probably be the first thing that I would think of. And then if you have women, and this is a large group of women who do not have obstructive coronary heart disease, they've had catheterizations, they've been to multiple providers, they've been to the ERs everywhere in the county, and they don't have obstructive coronary heart disease. They may have microvascular disease. They need aggressive secondary prevention, i.e. they do need statins, they do need ACE inhibitors, they may need beta blockers. They need lifestyle changes, probably more than anything else. Exercise, the right diet, and then symptomatically they may get relief from nitrates, from L-arginine, maybe tricyclic agents. And postmenopausal hormone therapy, I believe, is still very controversial, and hopefully we'll find out more information in the next 5 years. So sorry I ran over a little bit. I'm happy to take any questions.
Claire,
Yeah.
that was a great review. Thank you very, very much. I have a question about oral contraceptives and hypertension.
Mm-hmm.
Can you tell us kind of how we should manage those patients? Are the oral contraceptives unmasking an underlying proclivity for hypertension, or are they causing and increasing risks, and how should we approach
So I think the thing is that most young women are at very low risk, and most young women tend to have low blood pressures. I think that any estrogen-containing oral contraceptive is probably going to raise the blood pressure by a few points. That may not make any difference in the majority of patients, but you need to measure their blood pressure. And what I would say is in a young woman who has a borderline blood pressure to begin with, she would not be a good candidate for an estrogen-containing oral contraceptive. So that would be my strategy. And then I would continue to monitor blood pressure in that woman as she ages, because that's when her risk of hypertension goes way up. So that's the way I would handle it. Yeah.
As you know, we have this typical obstetric issue of peripartum cardiomyopathy.
Yes, I didn't have a chance to talk about that. I'm sorry.
And when you talk about coronary disease, I wonder if that's an indirect marker of cardiomyocyte health, and whether these women's changes are more related to the myocyte, not so much to the coronaries. People looked at that at all, at looking at more histologic changes of the muscle itself.
So I don't think we know why some women get peripartum cardiomyopathy. Clearly, it's a myocyte issue. It's not a coronary issue. The coronaries look beautiful in these women. They're wide open, pristine, but they have no contractile function left in their myocytes. The biggest thing that I can say, and I'm not aware of any literature that has found a mechanism for this. The biggest thing that I can say...
Apply to the other things that you're seeing. Maybe we're looking at the coronaries, and we should be looking at the myocytes,
Right.
why there is a gender difference.
That's a good question. That may be. I don't know. The most important thing from my perspective for peripartum cardiomyopathy, and the question that I get, is a woman who had peripartum cardiomyopathy, she's sort of recovered and her LV function is but it's not really normal, and she's thinking about getting pregnant again, or she is pregnant again. Then what do you do? So in those situations, we know that the risk of redeveloping and having a worsening peripartum cardiomyopathy is very high. So it's a big risk. Yeah, Tony. Hey.
I think one of the questions I always struggle with is, we're seeing a patient with a GYN subspecialty kind of commonly, and we get parts of the history, like you just said. We have a patient who has features of PCO, or who has a family history that seems out of the ordinary. What's really a struggle for us is figuring out what the right metacardiology treatment plan or source or referral for that patient is. Do you have suggestions either within the system or more broadly, how to approach that when we're seeing patients who out of the true primary care setting where that those flags come up?
So if a woman like that who has several risk factors, maybe she had pregnancy-induced hypertension, or she had preeclampsia, she has a strong family history of heart disease, she's got no symptoms now. The things that I would do, I don't jump to testing. A lot of women come to see me in my practice and they want to have a CT coronary angiogram, or they want to have this test or that test, and I tend to be not very aggressive with those tests, because what I tell them is I would do the same things for you with or without that test. If you're not having symptoms, there's not going to be anything I'm going to want to shove a catheter in your coronary for. What I will want you to do is exercise regularly. If you smoke, for God's sake, quit smoking. If you're overweight, commit to a healthy diet, and again, an exercise program. And if your cholesterol is borderline or elevated, I would strongly consider a statin. So those are the things that I would do. and there's no magic to it. There's not any one magic bullet that I'm going to do. It's just I'm going to have a little bit heightened awareness and probably a lower threshold for some preventive strategies.
Thank you.
All right.
Claire, thank you. That was a great,
Oh.
great talk.
You're welcome.
Really, really well presented.
Thank you.
So well presented.
Post-man